Hello and welcome. Do you want to successfully complete the D444 OA exam? Then you are in the right place. Our website has free questions and answers for the D444 OA exam. We know OA exams are tough, so our guides and practice questions are all free. With over 100 plus success stories, we have proven our videos will help you pass your exam on the first attempt. In this video, we will cover questions from respiratory disorders, acid-base balance, sensory pathologies, gastrointestinal diseases, neurological conditions. So, let's get started.
Question 1. A nurse is admitting an older adult patient with suspected pneumonia who has a fever and a productive cough with yellow sputum. The provider orders antibiotics, a sputum culture, supplemental oxygen, and fluids. Which action should the nurse complete first before starting the antibiotic? A. Start the prescribed oxygen. B. Administer fever, reducing medication. C. Obtain the sputum culture. D. Encourage oral fluid intake.
Can you guess the answer?
Correct answer. C. Obtain the sputum culture. The sputum specimen must be collected before antibiotics begin because antibiotic therapy alters bacterial growth in the sample and produces inaccurate culture results, which prevents the team from selecting the correctly targeted antibiotic. Option A is incorrect because oxygen supports hypoxia and can be started quickly, but it is not timing dependent the way cultures are. The priority remains capturing an untreated specimen before antibiotic therapy changes bacterial growth patterns. Option B is incorrect because fever-reducing medication improves comfort, but does not affect culture accuracy or treatment timing. Antibiotics must wait for specimen collection, and comfort medications can safely be given afterward without interfering with culture results. Option D is incorrect because fluid intake thins secretions and supports hydration, yet it is not a time-critical first action. The culture specimen must still be obtained first, because any delay after antibiotics reduces specimen accuracy significantly. Let's dig into the timing rule behind this pneumonia question. The correct answer is obtaining the sputum culture before starting antibiotics. When antibiotics hit the bloodstream, they start killing bacteria right away, including the ones sitting in the patient's sputum. If you grab the sample after that first dose, the lab may find nothing growing or the wrong organism growing, and the team loses the ability to pick a targeted antibiotic. Oxygen helps hypoxia. Fever medication improves comfort. Fluids thin secretions. None of those change lab results. Only the culture is time dependent. Here's a D444 OA exam tip for you. When you see a pneumonia question listing antibiotics alongside a culture order, the culture always comes first. Memory hook. Culture before cure. Question 2. A nurse is caring for an older adult who was admitted yesterday with pneumonia. The patient was oriented on admission but now appears restless, agitated, and confused. Which interpretation of this change should guide the nurse's next action? A. Early sign of hypoxia. B. Expected age-related response. C. Normal sleep disturbance. D. Medication side effect.
Can you guess the answer?
Correct answer. A. Early sign of hypoxia. Altered mental status including restlessness, agitation, and confusion is an early warning sign of hypoxia in pneumonia patients. The brain reacts quickly to decreased oxygen, so these changes demand immediate nursing assessment. Option B is incorrect, because attributing confusion to age alone is dangerous and delays care. Sudden mental status changes in older adults almost always signal a physiologic problem, most commonly hypoxia, infection progression, or worsening oxygenation status. Option C is incorrect, because sleep disturbance does not typically cause restlessness, agitation, and confusion together during daytime hours. These specific behavioral changes in a pneumonia patient reflect neurologic response to hypoxia rather than simple tiredness. Option D is incorrect because while some medications cause confusion, The pattern of new restlessness and agitation in a patient with active lung infection should first raise concern about oxygenation before medication side effects are considered. Here's a classic older adult pneumonia question, and the pattern trips up a lot of students. The patient was oriented yesterday. Today, restless, agitated, confused. The right interpretation is early hypoxia. The brain is the first organ to complain when oxygen drops, and in older adults that complaint often shows up as confusion or agitation, rather than shortness of breath. Age alone does not cause sudden mental status changes. Neither does sleep. Medication side effects sit lower on the list because the patient has an active lung infection that can drop oxygen delivery to the brain at any moment. Check oxygen saturation first, then work down the list. Here's a Wagyu D444 OA exam tip for you. New confusion in an older adult with any respiratory diagnosis equals hypoxia until proven otherwise. Memory hook: confused elder equals oxygen matter. Question 3. A patient admitted with lobar pneumonia reports increasing shortness of breath and chest tightness while lying flat in bed. The nurse wants to improve the patient's breathing and oxygenation before calling the provider. Which position should the nurse use? A. Supine with pillow under knees. B. Side lying on the affected lung. C. Prone with arms overhead. D. Semi-Fowlers with head elevated.
What do you think is the answer?
Correct answer. D. Semi-Fowlers with head elevated. Semi-Fowler's position elevates the head of bed and allows gravity to pull the diaphragm downward, which opens the lungs, promotes deeper breathing, and improves oxygenation and ventilation for patients with respiratory compromise. Option A is incorrect because supine position flattens the diaphragm and reduces lung expansion, which worsens breathing effort and oxygenation. This position is not appropriate for any patient who is actively experiencing dyspnea or chest tightness from pneumonia. Option B is incorrect because side lying on the affected side compresses the infected lung tissue further and can reduce oxygenation in the already compromised area. The good lung should face downward only in specific therapeutic situations. Option C is incorrect because prone positioning is used in severe respiratory distress, such as ARDS in critical care settings, but it is not the routine nursing intervention for a patient experiencing dyspnea on a medical floor. Let's talk through positioning for a pneumonia patient who is struggling to breathe. The right answer is semi-Fowlers with the head of the bed elevated. When a patient sits up, gravity pulls the abdominal contents downward, which lets the diaphragm drop and the lungs expand more fully. Lying flat does the opposite. The diaphragm gets pushed up by the belly contents, lung volumes shrink, and breathing gets harder. Side lying on the affected lung squishes the infected tissue, which cuts oxygenation in the area that already works poorly. Prone positioning belongs in critical care for severe cases like ARDS, not on medical floor for routine dyspnea. Here's a Wagyu D444 OA exam tip for you. Any patient short of breath needs the head of the bed up. Memory hook: when lungs struggle, sit them up. Question 4. A nurse is reviewing prescriptions for a patient hospitalized with bacterial pneumonia and productive cough with thick yellow sputum. The family asks why the provider has not ordered cough medicine to help the patient sleep. What is the nurse's best response? A. Cough suppressants cause dangerous drowsiness. B. Suppressing cough traps infected secretions. C. Cough syrup interacts with the antibiotics. D. The provider forgot to order it.
What do you think is the answer?
Correct answer. B. Suppressing cough traps infected secretions. Cough suppressants prevent clearance of infected mucus from the lungs, which allows bacteria-laden secretions to pool in the airways. This worsens the infection, reduces gas exchange, and delays patient recovery significantly. Option A is incorrect, because while drowsiness can occur with some cough preparations, it is not the primary reason providers withhold them in pneumonia. The main concern centers on preserving the productive cough that clears infected sputum. Option C is incorrect because common cough syrups do not have clinically significant interactions with standard pneumonia antibiotics like ciprofloxacin.I. The decision to avoid suppressants is based on protecting the cough reflex, not on medication interactions. Option D is incorrect because the provider did not forget. Withholding cough suppressants in pneumonia is an intentional clinical decision that supports airway clearance, and the nurse should never suggest that provider judgment was a simple oversight. This is a family teaching question, and the key concept is airway clearance. The right answer is that suppressing the cough traps infected secretions. In bacterial pneumonia, mucus is loaded with bacteria and pus. Coughing pushes all of that up and out. A cough suppressant shuts down that reflex, so the infected sputum pools in the airways, feeds the infection and blocks gas exchange. That is the opposite of what we want. Drowsiness can happen with some cough syrups, but it is not the main reason. Drug interactions with antibiotics like ciprofloxacin are not the concern here either, and the provider did not forget. Withholding cough suppressants is a deliberate choice to protect the productive cough. Here's a D444 OA exam tip for you. Productive cough in pneumonia is the treatment, not the problem. Memory hook. The cough is the cleanup crew. Question 5. A patient with pneumonia suddenly develops sharp chest pain on inspiration, asymmetrical chest expansion, and diminished breath sounds on the right side of the chest. The nurse suspects pleural effusion has developed as a complication. Which action should the nurse take first? A. Administer ordered pain medication. B. Encourage incentive spirometer use. C. Notify the healthcare provider. D. Reposition the patient to left side.
Do you know the answer?
Correct answer. C. Notify the healthcare provider. Asymmetrical chest expansion and diminished breath sounds suggest pleural effusion, which prevents full lung expansion and demands provider notification for possible thoracentesis. Delayed reporting allows the effusion to worsen gas exchange quickly. Option A is incorrect because pain medication may be appropriate later, but giving it first masks the worsening respiratory picture and delays the urgent provider notification needed to arrange thoracentesis or further imaging of the affected lung. Option B is incorrect because incentive spirometer use cannot resolve an established pleural effusion because the fluid in the pleural space mechanically blocks lung expansion. Encouraging deep breathing without first notifying the provider delays critical drainage decisions. Option D is incorrect because repositioning does not remove the fluid causing the respiratory compromise. The priority action is notifying the provider so diagnostic imaging and possible thoracentesis can be arranged quickly before respiratory status deteriorates. This is a pneumonia complication question, and the trigger phrase is asymmetrical chest expansion with diminished breath sounds on one side. Those findings point to pleural effusion, which is fluid collecting in the space around the lung. The correct action is to notify the provider first. Fluid in the pleural space blocks the lung from expanding, and the only way to fix that is drainage through thoracentesis. Nursing interventions alone will not move the fluid. Giving pain medication may help comfort, but it masks the picture and delays the call. Incentive spirometry cannot push past physical fluid in the chest cavity. Repositioning does not drain anything. The priority action is to get the provider on the phone so imaging and drainage can be arranged fast. Here's a D444 OA exam tip for you. One-sided chest findings in pneumonia means call the provider now. Memory hook. Asymmetry equals alarm. Question 6. A patient in the emergency department with a severe asthma attack was wheezing loudly on arrival. The nurse now notes that the patient's breath sounds are absent bilaterally, and the patient appears exhausted and cyanotic. How should the nurse interpret this change? A. Silent chest signals imminent respiratory failure. B. Patient is responding well to bronchodilators. C. Wheezing has resolved because inflammation decreased. D. Breath sounds are muffled by ambient room noise.
Do you know the answer?
Correct answer. A. Ayun. Silent chest signals imminent respiratory failure. A silent chest during active asthma means airflow has become so restricted that no air is moving through the airways. This pattern signals imminent respiratory failure and requires immediate emergency intervention and intubation preparation. Option B is incorrect because a patient improving from an asthma attack would show audible wheezing that gradually decreases along with improved oxygen saturation. Cyanosis and exhaustion alongside absent breath sounds never indicate a positive response to treatment. Option C is incorrect because wheezing does not resolve cleanly while a patient is cyanotic and exhausted. When airway inflammation truly resolves, breath sounds return clearly, and the patient's color, energy, and oxygen saturation all visibly improve. Option D is incorrect because room noise does not mask breath sounds during direct stethoscope auscultation in emergency settings. The absence of breath sounds in a struggling asthma patient reflects true airway closure, not an environmental listening problem. This is one of the scariest findings in respiratory nursing, and students need to recognize it instantly. Silent chest in an asthma patient does not mean the patient got better. It means no air is moving at all. Wheezing requires airflow through narrowed airways. When the airways close down completely, the wheezing stops because there is nothing for the air to vibrate against. Add cyanosis and exhaustion to the picture and you have respiratory failure knocking on the door. A patient actually improving would have audible wheezing that slowly softens with pink color and rising oxygen. Room noise does not erase breath sounds from a stethoscope. This patient needs immediate help, probably including intubation. Here's a BGU D444 OA exam tip for you. Silent chest in asthma is a crash signal, not a recovery sign. Memory hook. Silence in the lungs means prepare the tube. Question 7. A nurse is providing discharge teaching for a patient recently diagnosed with asthma. The patient also takes medications for chronic arthritis pain and high blood pressure. Which medication class on the patient's current list is most concerning and requires further follow-up? A. Topical corticosteroid creams. B. Oral acetaminophen tablets. C. Inhaled saline rinses. D. Non-steroidal anti-inflammatory drugs.
Do you know the answer?
Correct answer. D. Non-steroidal anti-inflammatory drugs. NSAIDs such as aspirin, ibuprofen, and naproxen can trigger severe bronchospasm in sensitive asthma patients. Beta blockers for blood pressure also carry this risk, so both classes warrant prescriber review before continued use. Option A is incorrect because topical corticosteroid creams act locally on the skin and have minimal systemic absorption or effect on airway reactivity. These creams do not provoke bronchospasm and are not a medication class of concern in asthma. Option B is incorrect because acetaminophen is generally considered safe for pain relief in patients with asthma because it does not affect the cyclooxygenase pathway the way NSAIDs do. It should not trigger asthma symptoms in most cases. Option C is incorrect because saline rinses are inert, rinses that help moisturize airways and remove irritants. They do not contain pharmacologic agents that could trigger bronchospasm and are often recommended for patients with respiratory conditions. This question tests medication safety for asthma patients. The concerning class is NSAIDs, the non-steroidal anti-inflammatory drugs like aspirin, ibuprofen, and naproxen. In some asthma patients, NSAIDs trigger severe bronchospasm through a prostaglandin pathway. The reaction can be fast and dangerous. Beta blockers for high blood pressure are another class to watch because they can narrow airways too. Topical steroid creams act on skin, not airways, so they are safe. Acetaminophen works on a different pathway and does not cause bronchospasm. Saline rinses are plain salt water and only help moisten the nose. The class that needs follow-up with the prescriber is NSAIDs. Here's a D444 OA exam tip for you. Asthma plus NSAID equals possible bronchospasm. Memory hook. No aspirin when airways twitch. Question 8. A new graduate nurse sees that the assigned COPD patient has an oxygen saturation reading of 90% and becomes alarmed. The charge nurse reminds the new nurse that this value may actually be within the expected range. Why is this true? A. Pulse oximeters measure inaccurately in COPD. B. COPD patients tolerate saturations of 88 to 93%. C. The patient is already on supplemental oxygen. D. Saturations below 95% are always normal.
What do you think is the answer?
Correct answer. B. COPD patients tolerate saturations of 88 to 93%. Chronic carbon dioxide retention in COPD causes patients to rely on low oxygen as their breathing drive, so an acceptable target range is 88 to 93%. Giving too much oxygen may actually suppress respirations. Option A is incorrect, because pulse oximeters generally provide reliable readings in COPD patients when the probe is placed correctly and perfusion is adequate. The reason a saturation of 90% is acceptable relates to the respiratory drive itself. Option C is incorrect, because supplemental oxygen use would be documented separately on the record and would not automatically explain why a lower baseline saturation is considered acceptable. The explanation relates to the chronic adaptation of COPD patients. Option D is incorrect, because saturations below 95% are not universally normal. For the average healthy adult, 95% or higher is expected. This is a teaching moment about COPD oxygen targets. A new nurse sees 90% and panics, but for a COPD patient that reading often sits inside the acceptable range of 88 to 93%. The reason comes down to how COPD patients breathe. In healthy people, rising carbon dioxide drives respiration. In long-standing COPD, carbon dioxide stays chronically high, so the body shifts over to low oxygen as the main breathing stimulus. Push the oxygen saturation too high and you knock out that hypoxic drive, slowing respirations and worsening carbon dioxide retention. Pulse oximeters still work in COPD. Supplemental oxygen use does not change the target range on its own. And below 95% is not automatically fine for everyone, just for COPD. Here's a D444 OA exam tip for you. COPD target, saturation is 88 to 93%. What? Memory hook, COPD lives in the low 90s. Question 9. A COPD patient arrives at the emergency department with new confusion, restlessness, and arterial blood gas results consistent with hypercapnic respiratory acidosis and rising carbon dioxide. The provider wants non-invasive respiratory support to prevent intubation. Which therapy should the nurse prepare to deliver first? A. Heated high-flow humidified nasal cannula. B. Simple face mask with added tubing. C. B-level positive airway pressure device. D. Room air with pursed lip breathing.
Do you know the answer?
Correct answer. C. B-level positive airway pressure device. BPAP is the first-line non-invasive therapy for hypercapnic respiratory failure because it actively assists ventilation on inspiration and maintains airway pressure on exhalation, which blows off excess carbon dioxide and improves acidosis. Option A is incorrect because high-flow nasal cannula delivers oxygen with humidity, but does not provide the two-level pressure support needed to actively drive out trapped carbon dioxide. It addresses oxygenation more than the underlying ventilation problem here. Option B is incorrect because simple face masks deliver oxygen without pressure support and cannot help remove retained carbon dioxide from the alveoli. This patient needs ventilation assistance, not just more oxygen, because the main problem is hypercapnia. Option D is incorrect because room air with pursed lip breathing cannot reverse established hypercapnic respiratory acidosis with confusion. The patient already shows mental status changes, which means breathing techniques alone have failed and mechanical support is required. Let's work through this COPD emergency question. The patient has confusion, restlessness, and blood gas results showing hypercapnic respiratory acidosis. Carbon dioxide is climbing, and the brain is reacting to it. The correct answer is BiPAP, B-level positive airway pressure. BiPAP delivers two different pressures, a higher one on inspiration to push air in, and a lower one on exhalation to keep airways opened. That pressure cycle actively moves trapped carbon dioxide out of the alveoli. Regular oxygen therapy through a high-flow cannula or face mask only addresses oxygenation. These patients have a ventilation problem, not just an oxygenation problem. Pursed-lip breathing on room air cannot fix a failing ventilation drive once confusion sets in. BiPAP can prevent intubation if it is started early enough. Here's a what you D444 OA exam tip for you. Hypercapnic respiratory failure with mental status changes means BiPAP first. Memory hook, Kyoto 2 climbing, BiPAP coming. Question 10. What? A nurse is teaching a patient with newly diagnosed asthma how to use a peak flow meter at home. The patient asks how to record the daily reading after completing 3 attempts in a row. What should the nurse advise the patient to do? A. Record the highest of the 3 attempts. B. Record the lowest of the 3 attempts. C. Record the average of all 3 attempts. D. Record only the very first attempt.
Can you guess the answer?
Correct answer. A. Record the highest of the 3 attempts. Patients should record the highest of 3 peak flow attempts because this best reflects the maximum airway function at that time. Using the highest reading provides consistent tracking of asthma control over time. Option B is incorrect because recording the lowest value would artificially make asthma control appear worse than it is, leading to unnecessary changes in treatment. Peak flow trending relies on best effort readings, not poorly executed or fatigued attempts. Option C is incorrect because averaging the 3 attempts can dilute the true peak capacity with weaker attempts that reflect technique rather than lung function. Standard teaching for peak flow monitoring is to use the highest of 3 attempts. Option D is incorrect because using only the first attempt ignores the guidance to repeat the maneuver and capture the best effort. Patients often perform better on the second or third attempt, so this approach would underestimate true peak flow. Peak flow meter teaching is a favorite exam topic because the rule is simple, but students mix it up. After 3 attempts in a row, the patient records the highest reading. The highest reading reflects the patient's true peak airway capacity on that day. Recording the lowest would pull the numbers down from fatigue or poor technique, making asthma look worse than it is. Averaging dilutes the best effort with weaker tries and smooths out meaningful changes. Taking only the first attempt skips the whole point of repeating the maneuver, which is to capture the best the patient can produce. Consistent tracking depends on the highest value each day, so zones and action plans stay accurate. Here's a big D444 OA exam tip for you. Peak flow equals highest of 3. Memory hook, best of 3 is what you see. Question 11. A nurse reviews arterial blood gas results for a patient with severe CPD and notes a low blood pH, along with an elevated carbon dioxide level. Based on the pattern of these results, which acid-base imbalance is the patient most likely experiencing? A. Metabolic acidosis from renal failure. B. Metabolic alkalosis from vomiting. C. Respiratory alkalosis from anxiety. D. Respiratory acidosis from CO2 retention.
Can you guess the answer?
Correct answer. D. Respiratory acidosis from CO2 retention. Respiratory acidosis is characterized by a low pH combined with elevated carbon dioxide because the lungs cannot remove carbon dioxide efficiently. COPD patients commonly trap carbon dioxide due to alveolar damage and weak gas exchange. Option A is incorrect because metabolic acidosis from renal failure shows low pH with low bicarbonate rather than high carbon dioxide. The kidneys cannot excrete acids properly, but that mechanism does not involve carbon dioxide retention by the lungs. Option B is incorrect because metabolic alkalosis from vomiting shows a high pH with elevated bicarbonate, not the low pH described. The acid loss from stomach contents causes the opposite acid-base picture compared to what this patient presents with. Option C is incorrect because respiratory alkalosis occurs with hyperventilation from anxiety and shows a high pH with low carbon dioxide because the patient blows off too much carbon dioxide. These findings contradict the elevated carbon dioxide seen here. Acid-base questions feel scary until you learn the pattern, and this one is pure respiratory acidosis. Low pH plus high carbon dioxide equals respiratory acidosis, period. The lungs are not clearing carbon dioxide fast enough, so it builds up in the blood, combines with water, and forms carbonic acid. That drops the pH. COPD fits this picture because damaged alveoli cannot push carbon dioxide out efficiently. Metabolic acidosis from renal failure shows low pH with low bicarbonate, not high carbon dioxide. Metabolic alkalosis from vomiting shows high pH with high bicarbonate, the opposite direction. Respiratory alkalosis from anxiety shows high pH with low carbon dioxide because hyperventilation blows the carbon dioxide off. Pattern recognition wins these questions. Here's a big D444 OA exam tip for you. Low pH plus high CO2 equals respiratory acidosis. Memory hook, Rome method. Respiratory opposite, metabolic equal. Question 12. A postoperative patient has been vomiting for several hours and now has a nasogastric tube connected to low suction. The nurse suspects an acid-base imbalance is developing based on the ongoing loss of stomach contents. Which imbalance is most likely to develop? A. Respiratory acidosis from hypoventilation. B. Metabolic alkalosis from hydrogen ion loss. C. Respiratory alkalosis from hyperventilation. D. Metabolic acidosis from diarrhea.
What do you think is the answer?
Correct answer. B. Metabolic alkalosis from hydrogen ion loss. Vomiting and nasogastric suction remove hydrochloric acid from the stomach, which lowers the body's hydrogen ion pool. This loss of acid raises the pH and bicarbonate level, producing metabolic alkalosis in the patient. Option A is incorrect because respiratory acidosis occurs with hypoventilation and carbon dioxide buildup, which is unrelated to vomiting and stomach fluid loss. This patient has no breathing problem described in the scenario that would cause carbon dioxide retention. Option C is incorrect because respiratory alkalosis develops during hyperventilation when too much carbon dioxide is exhaled, often during anxiety or pain responses. Vomiting and gastric suction do not affect respiratory rate enough to cause this imbalance directly. Option D is incorrect because metabolic acidosis develops from diarrhea due to loss of bicarbonate in liquid stools, not from vomiting. The acid-base picture flips completely depending on whether losses come from the upper or lower digestive tract. This is a classic postoperative acid-base question. Vomiting plus nasogastric suction equals loss of stomach contents, and stomach contents are rich in hydrochloric acid. When the body loses acid, the blood pH rises and bicarbonate climbs with it. That is metabolic alkalosis. Respiratory acidosis needs a breathing problem, which this patient does not have. Respiratory alkalosis comes from hyperventilation, and again there is no breathing issue described. Metabolic acidosis from diarrhea fits the lower gastrointestinal tract, where the body loses bicarbonate in watery stools. Stomach losses and intestinal losses produce opposite acid-base pictures, which is a favorite exam trap. Here's a D444 OA exam tip for you. Vomit or suction loses acid, pH goes up, metabolic alkalosis. Memory hook, vomit up, pH up. Question 13. A patient is admitted with severe diarrhea lasting several days and reports dizziness and muscle weakness. The nurse reviews laboratory results and expects to find evidence of an acid-base imbalance related to the fluid losses from the lower gastrointestinal tract. Which finding is most likely? A. Low pH with decreased bicarbonate levels. B. High pH with increased bicarbonate levels. C. Low pH with increased carbon dioxide levels. D. High pH with decreased carbon dioxide levels.
Do you know the answer?
Correct answer. A. Low pH with decreased bicarbonate levels. Severe diarrhea causes large bicarbonate losses from the intestines, leading to metabolic acidosis. The resulting low pH, combined with low bicarbonate, is the classic laboratory pattern seen in lower gastrointestinal tract fluid losses. Option B is incorrect, because a high pH with high bicarbonate indicates metabolic alkalosis, which more commonly develops from vomiting or nasogastric suction. Diarrhea removes bicarbonate from the body, so the opposite pattern would be expected in this case. Option C is incorrect, because a low pH with high carbon dioxide describes respiratory acidosis, which arises from impaired ventilation rather than intestinal losses. This patient has no respiratory problem described that would cause carbon dioxide to rise significantly. Option D is incorrect because a high pH with low carbon dioxide reflects respiratory alkalosis from hyperventilation. This does not match the clinical situation of prolonged diarrhea, which causes metabolic rather than respiratory changes in acid-base balance. Severe diarrhea is the other side of the gastrointestinal coin. The lower gut is loaded with bicarbonate, so fluid loss from that region strips bicarbonate out of the body. When bicarbonate drops, the blood's buffer pool shrinks and acids accumulate. The pH falls. That combination, low pH with low bicarbonate, is metabolic acidosis. High pH with high bicarbonate is metabolic alkalosis, which fits vomiting instead. Low pH with high carbon dioxide is respiratory acidosis from a breathing failure. High pH with low carbon dioxide is respiratory alkalosis from hyperventilation. Stick with the pattern. Diarrhea loses base, so the body tips acidic. Here's a D444 OA exam tip for you. Diarrhea drops bicarbonate, producing metabolic acidosis. Memory hook. Down the toilet, down the pH die. Question 14. A patient with type 1 diabetes arrives with deep rapid breathing, fruity breath odor, and drowsiness. The nurse suspects diabetic ketoacidosis has developed and prepares to review the arterial blood gas results with the provider. Which finding best supports this suspicion? A. High pH and high bicarbonate level. B. High pH and low carbon dioxide level. C. Low pH and low bicarbonate level. D. Low pH and high carbon dioxide level.
What do you think is the answer?
Correct answer. C. Low pH and low bicarbonate level. Diabetic ketoacidosis produces ketone acids that consume bicarbonate buffers and drop the blood pH sharply. The classic pattern is low pH with low bicarbonate, reflecting a metabolic cause rather than a respiratory origin. Option A is incorrect, because a high pH and high bicarbonate pattern reflects metabolic alkalosis, which occurs with vomiting or gastric suction. This pattern does not fit diabetic ketoacidosis, where acid accumulation and bicarbonate consumption are the main events. Option B is incorrect, because a high pH with low carbon dioxide describes respiratory alkalosis from hyperventilation alone. While DKA patients breathe rapidly, the underlying acid load drops the pH, so the pH in DKA moves downward, not upward. Option D is incorrect, because a low pH with high carbon dioxide indicates respiratory acidosis, which arises from poor ventilation. DKA causes rapid deep breathing that lowers carbon dioxide as compensation, so carbon dioxide would not be elevated here. Diabetic ketoacidosis, or DKA, is one of the most tested acid-base imbalances in nursing school. The picture is deep rapid breathing called Kussmaul respirations, fruity breath from ketones and drowsiness. Behind the scenes, the body is breaking down fat for fuel, producing ketone acids that flood the bloodstream. Those acids use up bicarbonate, and the pH drops. So the lab pattern is low pH with low bicarbonate. The rapid breathing you see is compensation. The body tries to blow off carbon dioxide to counter the acid load. That is why carbon dioxide actually goes down in DKA, not up. High pH answers belong to alkalosis, not acidosis, so those are out. Low pH with high carbon dioxide belongs to respiratory acidosis, which is a totally different mechanism. Here's a D444 OA exam tip for you. DKA equals low pH plus low bicarbonate. Memory hook, ketones eat the bicarb. Question 15. A patient comes to the emergency department with a panic attack and reports rapid, deep breathing along with numbness in the fingertips and around the mouth. The nurse recognizes these symptoms match a specific acid-base imbalance. Which imbalance best fits this presentation? A. Metabolic acidosis from excess acid production. B. Metabolic alkalosis from acid loss in stomach. C. Respiratory acidosis from carbon dioxide buildup. D. Respiratory alkalosis from excess CO2 exhalation.
Do you know the answer?
Correct answer. D. Respiratory alkalosis from excess CO2 exhalation. Anxiety-driven hyperventilation removes carbon dioxide from the body too quickly, which raises blood pH and produces respiratory alkalosis. The numb fingertips and mouth reflect calcium shifts that accompany this rapid acid-base change. Option A is incorrect because metabolic acidosis involves acid buildup and drops the pH downward rather than upward. The scenario describes fast breathing caused by panic, not a metabolic process like ketoacidosis or renal failure that would drive pH down. Option B is incorrect because metabolic alkalosis from stomach acid loss is possible after vomiting, but this patient has not lost stomach contents. The described presentation involves breathing changes, driving the imbalance, not upper gastrointestinal fluid loss. Option C is incorrect because respiratory acidosis occurs when carbon dioxide builds up from poor ventilation, not from fast deep breathing. The patient is hyperventilating, which moves carbon dioxide out of the body rather than trapping it inside. Panic attack acid base is the mirror image of the COPD question earlier. The patient is hyperventilating, breathing fast and deep, which blows carbon dioxide out of the lungs much faster than the body produces it. Carbon dioxide drops, pH rises, and the result is respiratory alkalosis. The numb fingertips and tingling around the mouth come from calcium shifting on proteins as the pH changes. Calcium binds more tightly when the blood gets alkalotic, so the free calcium drops and nerves misfire. Metabolic acidosis drops the pH through acid production, not rapid breathing. Metabolic alkalosis from stomach acid loss does not fit a patient who has not vomited. Respiratory acidosis needs trapped carbon dioxide, which is the opposite of hyperventilation. Here's a D444 OA exam tip for you. Hyperventilation equals respiratory alkalosis with tingling. Memory hook, blow it off, alkalosis. Question 16. A patient arrives at urgent care reporting sudden severe pain in the right eye, blurred vision with halos around lights, nausea, and a reddened sclera. The symptoms began abruptly while the patient was watching a movie in a dimly lit theater. Which condition fits this presentation? A. Chronic open-angle glaucoma with slow progression. B. Acute angle closure glaucoma with sudden onset. C. Bacterial conjunctivitis with drainagens. D. Ordinary eye fatigue from screen use.
Can you guess the answer?
Correct answer. B. Acute angle closure glaucoma with sudden onset. Angle closure glaucoma causes sudden severe eye pain, halos around lights, nausea, and reddened sclera when the iris blocks aqueous humor outflow. Dim lighting dilates the pupil, which triggers the attack in susceptible eyes. Option A is incorrect, because open-angle glaucoma develops gradually with painless loss of peripheral vision and mild eye aching rather than sudden severe pain. The rapid onset and intense symptom picture do not match the slower, quieter open-angle pattern. Option C is incorrect because bacterial conjunctivitis presents with eye discharge, crusting on awakening, and mild itching or burning rather than severe pain with nausea and halos. The sudden severe symptoms described here point to an emergency inside the eye. Option D is incorrect because ordinary eye fatigue causes mild tiredness, dryness, or minor discomfort that improves with rest. Fatigue never produces severe pain with nausea, halos around lights, and a reddened sclera that requires urgent evaluation. Eye emergencies show up on every nursing exam, and this one is a textbook angle closure glaucoma attack. The trigger here is the dim theater. In low light, the pupil dilates, which pushes the iris into the narrow drainage angle of the eye and blocks aqueous humor outflow. Pressure inside the eye spikes fast, causing severe pain, blurred vision with halos, nausea, and a red sclera. The whole picture comes on in minutes to hours. Open-angle glaucoma progresses over years, is painless, and steals peripheral vision quietly. Bacterial conjunctivitis causes discharge, crusting, and itching, not severe pain with halos. Eye fatigue feels mild and improves with rest. Nothing else in the options matches sudden severe pain with nausea. Here's a what you D444 OA exam tip for you. Sudden eye pain with halos equals angle closure glaucoma. Memory hook. Dim light closes the angle. Question 17. An older adult patient mentions during a routine checkup that recently they have been bumping into objects on the sides of doorways and missing steps. The patient has not had any eye pain but does report mild headaches. Which condition does the nurse suspect? A. Primary open-angle glaucoma. B. Acute angle closure glaucoma. C. Sudden retinal detachment. D. Anterior eye trauma.
Do you know the answer?
Correct answer. A. Primary open-angle glaucoma. Primary open-angle glaucoma progresses slowly and painlessly, gradually narrowing peripheral vision. Patients commonly notice bumping into things and missing steps before any central vision loss occurs, which is why routine screening matters so much. Option B is incorrect, because acute angle closure glaucoma presents with severe eye pain, nausea, and halos rather than quiet peripheral vision loss. The sudden intense presentation of angle closure does not match this patient's gradual and painless symptom history. Option C is incorrect because retinal detachment usually produces sudden flashes of light, floaters, or a curtain falling across vision rather than slow peripheral loss with headaches. The time course and symptom type do not fit this patient's presentation. Option D is incorrect because anterior eye trauma produces obvious injury findings such as pain, redness, vision blur, or visible damage to the eye. Nothing in the history describes an injury event, which rules out trauma as the likely cause. This patient is showing the quiet side of glaucoma. Bumping into doorways and missing steps means peripheral vision is shrinking. No eye pain and only mild headaches means the pressure has been rising slowly over years. That matches primary open-angle glaucoma perfectly. Open-angle glaucoma is often called the silent thief of sight because it causes no discomfort until the vision loss is already significant. The drainage angle stays open, but the microscopic drainage structures fail. Pressure builds up gradually, and the optic nerve slowly dies from the outside in. Acute angle closure would bring severe pain, nausea, and halos, not a quiet peripheral loss. Retinal detachment flashes lights and drops a curtain across vision suddenly. Eye trauma shows obvious injury findings. Here's a D444 OA exam tip for you. Painless peripheral vision loss equals open-angle glaucoma. Memory hook, silent sides, silent thief. Question 18. A patient presents with an acute attack of angle closure glaucoma, including severe eye pain, nausea, and vomiting. The provider needs a medication that will rapidly lower intraocular pressure by pulling fluid from the eye. Which medication is the nurse most likely to prepare? A. Topical antibiotic ointment. B. Oral acetaminophen tablet. C. Intravenous osmotic diuretic. D. Topical anesthetic drop.
What do you think is the answer?
Correct answer. C. Intravenous osmotic diuretic. Mannitol is an osmotic diuretic that rapidly pulls fluid out of the eye to decrease intraocular pressure during an acute angle closure attack. Its rapid onset makes it the emergency choice when vision is threatened. Option A is incorrect because topical antibiotic ointment treats bacterial infections of the eye surface and has no effect on intraocular pressure. Glaucoma in emergencies involve fluid dynamics inside the eye, not surface bacterial processes, so antibiotics will not help. Option B is incorrect because acetaminophen relieves mild pain but has no action on aqueous humor drainage or intraocular pressure. The patient needs a medication that addresses the underlying pressure directly, not just the pain symptom. Option D is incorrect because topical anesthetic drops numb the surface of the eye for brief procedures, but do not reduce intraocular pressure. They are never used as treatment for glaucoma attacks or routine glaucoma management in clinical practice. Angle closure glaucoma is a true eye emergency, and the goal is to drop intraocular pressure fast before the optic nerve dies. The right answer is intravenous osmotic diuretic, usually mannitol. Mannitol pulls fluid out of the eye by raising the osmotic pressure of the blood, which yanks water from the aqueous humor into circulation and then out through the kidneys. Pressure drops within minutes, buying time for definitive surgery. Topical antibiotic ointment works on bacterial infections of the eye surface. It does nothing for pressure. Oral acetaminophen helps mild pain but has no pressure effect. Topical anesthetic drops numb the eye for procedures and never treat glaucoma. Here's a D444 OA exam tip for you. Acute glaucoma equals the fourth mannitol. Memory hook: mannitol pulls the pressure out. Question 19. A patient with newly diagnosed open-angle glaucoma has been prescribed daily eye drops to control intraocular pressure long-term. The patient asks the nurse how these drops lower the pressure inside the eye. Which explanation should the nurse provide to the patient? A. Drops dry out the aqueous humor completely. B. Drops replace damaged optic nerve fibers. C. Drops dilate the pupil to widen the eye. D. Drops reduce production or improve outflow.
Can you guess the answer?
Correct answer. D. Drops reduce production or improve outflow. Glaucoma eye drops such as timolol reduce aqueous humor production, while others like travoprost improve outflow of the fluid. Both mechanisms lower intraocular pressure to protect the optic nerve from further gradual damage. Option A is incorrect because eye drops never completely dry out the aqueous humor because the eye requires this fluid for shape and nourishment of the lens and cornea. The drops adjust balance, not eliminate the fluid entirely from the eye. Option B is incorrect because no eye drop can replace damaged optic nerve fibers, which is why early detection of glaucoma matters so much. Drops only prevent further damage by controlling pressure, but cannot restore vision that has already been lost. Option C is incorrect because glaucoma drops typically constrict the pupil or decrease fluid production rather than dilate the pupil. Dilating the pupil could actually make angle closure glaucoma worse by blocking outflow pathways even more severely inside the eye. Long-term glaucoma drops work through two different mechanisms, and the nurse has to explain both to the patient. Some drops reduce the amount of aqueous humor the eye produces. Timolol, a beta blocker drop, fits this group. Other drops increase the outflow of aqueous humor through the drainage structures. Travoprost, a prostaglandin analog, is a common example. Either way, the math is the same. Less fluid coming in or more fluid going out equals lower pressure inside the eye. Drops never dry the eye out completely because the aqueous humor feeds the lens and cornea and keeps the eye round. Drops cannot replace dead nerve fibers, which is why early detection is so important. Dilating the pupil would actually worsen angle closure glaucoma, so drops constrict the pupil or work through chemistry instead. Here's a D444 OA exam tip for you. Glaucoma drops either reduce inflow or increase outflow. Memory hook, less in or more out. Question 20. The nurse is assessing risk factors for primary open-angle glaucoma during an initial clinic visit. The patient asks which of their personal characteristics might increase their chances of developing this eye condition. Which factor is most strongly associated with increased risk? A. Regular use of reading glasses since childhood. B. Advancing age and a positive family history. C. Consumption of leafy green vegetables daily. D. Wearing sunglasses on sunny summer days.
What do you think is the answer?
Correct answer. B. Advancing age and a positive family history. Primary open-angle glaucoma risk increases strongly with advancing age and family history, along with diabetes and hypertension. These factors affect the eye's drainage structures and optic nerve sensitivity to pressure changes over decades of life. Option A is incorrect, because needing reading glasses from childhood relates to refractive errors rather than glaucoma risk. Corrective lens use does not cause or predict the development of glaucoma, which involves fluid and optic nerve issues instead. Option C is incorrect because eating leafy green vegetables is generally protective for eye health and overall wellness, not a risk factor for glaucoma. Healthy dietary habits reduce the risk of several chronic eye conditions, rather than contributing to them. Option D is incorrect because wearing sunglasses protects the eyes from ultraviolet damage and reduces cataract risk. Sun exposure is not a major direct risk factor for open-angle glaucoma, which is most strongly linked to age and family history. Risk factor questions reward students who know the big hitters. For primary open-angle glaucoma, the strongest links are advancing age and a positive family history. Age matters because the drainage structures lose efficiency over decades, and genetics matters because the shape and function of those structures run in families. Diabetes and hypertension also raise risk by damaging the small blood vessels that feed the optic nerve. Reading glasses since childhood point to refractive errors, which have nothing to do with glaucoma. Leafy greens are protective for eye health through nutrients like lutein and zeaxanthin. Sunglasses protect against ultraviolet damage and cataracts, but do not prevent or cause open-angle glaucoma. The correct pairing is always age plus family history. Here is a D444 OA exam tip for you. Open-angle glaucoma risk equals age plus family history, DAOS. Memory hook, older eyes plus family ties. Question 21. A patient has just been admitted with suspected active tuberculosis. The nurse is preparing the patient's room and gathering the required personal protective equipment for staff entering the area. Which room and equipment setup should the nurse arrange for this patient? A. Standard room with surgical mask. B. Private room with gown and gloves. C. Negative pressure room with 95 respirator. D. Semi-private room with basic droplet mask.
What do you think is the answer?
Correct answer. C. Negative pressure room with 95 respirator. Active tuberculosis spreads through airborne droplet nuclei that remain suspended in the air for hours. A negative pressure room prevents escape of infectious particles, and fit-tested 95 respirators protect staff from inhaling the bacteria. Option A is incorrect, because a standard room and surgical mask do not provide adequate protection against airborne tuberculosis particles. Surgical masks cannot filter the small droplet nuclei, and a standard room allows particles to travel out to shared hallways. Option B is incorrect because gowns and gloves in a private room fit a contact precaution setup rather than airborne precautions. Tuberculosis requires respiratory protection at the N95 level and specialized room engineering to control airborne particle movement. Option D is incorrect because semi-private rooms and droplet masks would expose roommates and staff to airborne particles, which poses a serious infection control risk. Tuberculosis demands true airborne isolation, not less stringent droplet-level precautions. Tuberculosis isolation is one of the most tested infection control topics, and the setup has to be exact. Active TB travels through tiny droplet nuclei that hang in the air for hours, so regular barriers do not work. The correct answer is a negative pressure room plus a fit-tested 95 respirator. Negative pressure pulls air into the room so that infectious particles cannot drift out into hallways. The ND5 filters out particles small enough to reach the alveoli. A standard room and surgical mask leak on both ends. The particles escape the room and slip through the mask. Gown and gloves cover contact, spread like MRSA, but miss airborne bugs entirely. Semi-private rooms with droplet masks expose roommates and still fail to block the small nuclei. Here's a D444 OA exam tip for you. TB equals airborne precautions, always. Memory hook, negative pressure plus 95 for nuclei.e. Question 22. Ice. A nurse is teaching a patient who has just started rifampin as part of a tuberculosis treatment plan. The patient asks about any noticeable body changes they might experience while on the medication. Which expected effect should the nurse describe to the patient? A. Reddish-orange discoloration of body fluids. B. Tingling in the fingertips and feet. C. Yellow pigmentation of the sclera and skin. D. Ringing in the ears with dizziness.
What do you think is the answer?
Correct answer. A. Reddish-orange discoloration of body fluids. Rifampin causes body fluids such as urine, tears, sweat, and saliva to turn reddish-orange. This effect is harmless, but patients should be warned because it can permanently stain soft contact lenses during use. Option B is incorrect, because tingling in fingertips suggests peripheral neuropathy, which is linked to isoniazid rather than rifampin. Isoniazid reduces vitamin B6 levels, so supplemental B6 is given with that specific drug to prevent nerve damage. Option C is incorrect because yellow pigmentation of the sclera and skin indicates jaundice, which is a red flag for hepatotoxicity, not an expected effect. Any jaundice should be reported immediately to the provider rather than accepted as normal. Option D is incorrect because ringing in the ears and dizziness describe ototoxicity, which is linked to medications like aminoglycosides and vancomycin. These symptoms are not typical side effects of rifampin and should be investigated for other causes. Rifampin teaching usually shows up as an expected side effect question. The right answer is reddish-orange discoloration of body fluids. Urine, tears, sweat, and saliva all turn a rusty orange color during treatment, which can permanently stain soft contact lenses and light clothing. Patients need to know this is harmless, so they do not panic or stop the drug. Tingling in fingertips and feet points to peripheral neuropathy from isoniazid, which is a different TB drug that depletes vitamin B6. Yellow sclera and skin means jaundice, which signals liver toxicity and demands immediate reporting. Ringing in the ears with dizziness is ototoxicity, usually linked to aminoglycosides or vancomycin, not rifampin. Teach the orange as expected. Teach the yellow as a red flag. Here's a D444 OA exam tip for you. Rifampin equals red-orange fluids. Memory hook. Rifampin paints a rust-colored picture. Question 23. A patient on isoniazid for tuberculosis reports new numbness and tingling in both feet during a follow-up clinic visit. The nurse recognizes that a specific nutritional deficiency explains these new symptoms. Which supplement is most commonly added to prevent this problem? A. Vitamin C ascorbic acid. B. Vitamin D cholecalciferol. C. Vitamin A retinol. D. Vitamin B6 pyridoxine.
What do you think is the answer?
Correct answer. D. Vitamin B6 pyridoxine. Isoniazid interferes with vitamin B6 absorption, which leads to peripheral neuropathy, with numbness and tingling of the extremities. Patients on isoniazid routinely take pyridoxine supplementation to prevent this nerve-related side effect from developing further. Option A is incorrect, because vitamin C supports wound healing and immune function, but does not prevent isoniazid-related neuropathy. Patients do not routinely need extra vitamin C during tuberculosis therapy unless they have an unrelated deficiency that warrants supplementation. Option B is incorrect, because vitamin D supports bone health and calcium absorption, and has no known role in preventing isoniazid neuropathy. The deficiency pattern caused by isoniazid specifically involves the vitamin B6 pathway in nerve tissue function. Option C is incorrect because vitamin A supports vision and skin health rather than peripheral nerve function. Too much vitamin A can actually be toxic, so it is never used as routine supplementation during tuberculosis drug therapy in this scenario. Isoniazid is the TB drug that loves to steal vitamin B6. Without enough B6, peripheral nerves start to misfire, and patients feel numbness and tingling in the hands and feet. The correct supplement to prevent this is vitamin B6, also called pyridoxine. It is added routinely when patients start isoniazid, not as a treatment after symptoms appear, but as prevention from day one. Vitamin C helps with wound healing and immune support, but does nothing for isoniazid neuropathy. Vitamin D supports bone health and calcium balance, which is an unrelated pathway. Vitamin A supports vision and skin cells and can actually become toxic at high doses, so adding it without reason is dangerous. The pairing to memorize is isoniazid plus B6 every time. Here's a buggy D444 OA exam tip for you. Isoniazid equals pyridoxine B6. Memory hook. INA plus B6 keeps nerves fixed. Question 24. A patient is being started on a 4-drug tuberculosis regimen including rifampin, isoniazid, pyrazinamide, and ethambutol. The nurse reviews the patient's history and identifies one shared concern that applies across all 4 of these medications. Which concern applies to the whole regimen? A. Cardiac rhythm disturbances and arrhythmias. B. Liver toxicity with elevated enzymes. C. Kidney failure with rising creatinine. D. Bone marrow suppression with low platelets.
Can you guess the answer?
Correct answer. B. Liver toxicity with elevated enzymes. All 4 first-line tuberculosis drugs can damage the liver, which is why baseline and ongoing liver function tests are required. Patients also need alcohol counseling and careful acetaminophen limits during the full treatment course. Option A is incorrect, because cardiac rhythm disturbances are not a shared concern across the 4 standard tuberculosis medications. The overlapping concern involves the liver rather than the heart, and cardiac monitoring is not routine for this drug regimen. Option C is incorrect, because kidney injury can occur with some medications, but it is not the primary shared concern across the standard tuberculosis regimen. The liver carries far more risk, which is why liver enzymes are monitored so closely. Option D is incorrect, because bone marrow suppression is seen with chemotherapy agents and some antibiotics, but it is not the major concern for the standard 4-drug tuberculosis regimen. The liver remains the primary organ at risk for these drugs. The 4-drug TB regimen is rifampin, isoniazid, pyrazinamide, and ethambutol, often abbreviated RIPE. The shared concern that applies to all 4 is liver toxicity. Every one of these drugs can damage liver cells, so baseline liver enzymes are checked before therapy starts and monitored during treatment. Patients also get alcohol counseling and careful acetaminophen limits to reduce the combined stress on the liver. Cardiac arrhythmias are not shared across this regimen because the drugs do not target conduction pathways. Kidney injury can happen with ethambutol in specific cases, but liver risk dominates across the board. Bone marrow suppression fits chemotherapy agents, not standard TB drugs. When you see all 4 drugs listed together, always think liver. Here's a Ouija with you, D444 OA exam tip for you. RIPE equals liver monitoring. Memory hook. RIPE drugs ripen the liver. Watch enzymes. Question 25. A provider orders sputum cultures to confirm active pulmonary tuberculosis for a patient admitted to the medical unit overnight. The nurse is planning the specimen collection schedule for the best diagnostic accuracy. How should the nurse arrange the collection of these specimens? A. Early morning, sterile samples for 3 consecutive days. B. 1. Mid-afternoon sample with saline induction. C. Random samples taken during any coughing episode. D. Single evening sample sent urgently to the lab.
Do you know the answer?
Correct answer. A. The early morning sterile samples for 3 consecutive days. Early morning specimens contain overnight accumulated secretions and yield the highest concentration of mycobacteria for culture. 3 consecutive morning samples are standard to maximize diagnostic accuracy and confirm or rule out active pulmonary tuberculosis reliably. Option B is incorrect, because a single mid-afternoon induced sample does not match the standard protocol for tuberculosis diagnosis. The best yield comes from morning specimens on 3 consecutive days, which capture concentrated secretions after overnight pooling in the lungs. Option C is incorrect, because random samples collected during coughing episodes are not standardized and may lack adequate volume or organism concentration. Structured early morning collection over 3 days produces the most reliable results for sputum culture confirmation. Option D is incorrect, because a single evening sample does not provide the diagnostic confirmation needed for a potentially serious infection. Tuberculosis diagnosis requires a set of 3 consecutive morning specimens to improve sensitivity and support accurate treatment decisions. Sputum collection for TB has a very specific protocol, and exam questions test whether students know it. The right answer is early morning sterile specimens collected on 3 consecutive days. Overnight, secretions pool in the lungs and concentrate the bacteria, so the first cough of the morning gives the richest sample. 3 days in a row improves sensitivity because not every specimen contains enough organisms to show up. 1 mid-afternoon induced sample does not match the protocol. A single sample misses organisms that only appear in subsequent collections. Random coughing specimens vary in volume and quality, so the lab cannot rely on them for a definitive diagnosis. 1 evening sample sent urgently sounds efficient, but fails the sensitivity standard. The rule is 3 mornings, sterile, consecutive days. Here's a D444 OA exam tip for you. TB sputum equals 3 early morning samples. Memory hook, 3 mornings, 3 samples, 1 diagnosis. Question 26. A nurse is preparing to admit a patient diagnosed with active measles to the medical floor. The charge nurse asks about the type of isolation precautions required to protect staff and other patients from exposure. Which precautions should the nurse prepare? A. Contact precautions with gown and gloves only. B. Droplet precautions with surgical mask. C. Airborne precautions with N95 respirator. D. Standard precautions with hand hygiene.
What do you think is the answer?
Correct answer. C. Airborne precautions with N95 respirator. Measles, tuberculosis, varicella, and disseminated shingles spread through airborne droplet nuclei that stay suspended in air. Airborne precautions require a negative pressure room, N95 respirator, and a closed door to protect others. Option A is incorrect, because contact precautions use gown and gloves and fit organisms that spread by touch, such as inner SA or C. diff. Measles particles float through the air, so touching surfaces is not the primary transmission route. Option B is incorrect because droplet precautions apply to respiratory illnesses spread by large droplets over short distances, such as influenza or meningitis. Measles particles are smaller and travel further, so droplet-level protection cannot block them adequately. Option D is incorrect because standard precautions apply to every patient encounter, but do not add the specialized barriers needed for airborne diseases. Measles requires an additional tier of protection beyond the baseline hygiene practices used for all patients. Measles is airborne, just like tuberculosis, varicella, and disseminated shingles. The correct precaution is airborne with an N95 respirator and a negative pressure room with the door kept closed. Measles particles are small enough to float for extended periods and travel longer distances than droplet-sized particles. Contact precautions with only gown and gloves fit organisms that spread by touch, like MRSA or C. diff, which misses the air route entirely. Droplet precautions with a surgical mask fit influenza or meningitis, where larger droplets fall within a few feet, but they cannot block the tiny measles particles. Standard precautions are the baseline for every patient, and never enough on their own for a truly airborne disease. Here's a Wagyu D444 OA exam tip for you. Measles equals airborne, 95, negative pressure. Memory hook. My chicken has TB, measles, chickenpox, herpes zoster disseminated, tuberculosis all go airborne. Question 27. A nurse is caring for a patient with suspected Clostridium difficile infection and severe watery diarrhea. After providing care, the nurse removes gloves and prepares to perform hand hygiene before moving to the next patient. Which hand hygiene method is required? A. Alcohol-based hand sanitizer rub. B. Antimicrobial wipes on the hands. C. Quick rinse under running water. D. Soap and running water wash.
What do you think is the answer?
Correct answer. D. Soap and running water wash. C. Difficile produces spores that resist alcohol-based hand sanitizers. Hand hygiene after C. difficile care must be done with soap and running water, because the physical friction and rinsing removes spores from the skin. Option A is incorrect, because alcohol-based hand sanitizer kills many bacteria and viruses, but does not destroy C. difficile spores. Using sanitizer alone after caring for these patients can leave infectious spores on the hands and spread the infection. Option B is incorrect, because antimicrobial wipes share the same weakness as alcohol rubs when it comes to spore-forming bacteria like C. difficile. They cannot physically remove spores, so they do not meet the required hygiene standard here. Option C is incorrect, because a quick rinse without soap does not provide the scrubbing action or surfactant effect needed to lift spores off the skin. Soap combined with mechanical friction under running water is required for true spore removal. C. diff hand hygiene is a classic trick question. Alcohol-based hand sanitizer feels like the right answer because it is everywhere in the hospital, but it fails against C. diff. The organism produces spores that resist alcohol, so the sanitizer leaves them alive on the hands. The correct method is soap and running water with mechanical scrubbing. The combination of surfactant action from soap, friction from scrubbing, and flow from running water physically lifts the spores off the skin and washes them down the drain. Alcohol rubs kill many bacteria and viruses, but not spore formers. Antimicrobial wipes share the same weakness. A quick rinse without soap does not create the surfactant effect needed to release spores. Wash, do not rub. Here's a Wagyu D444 OA exam tip for you. C. diff equals soap and water only. Memory hook, spores need scrub. Question 28. A nurse is assigned to a patient admitted with suspected bacterial meningitis and fever. The nurse is preparing the room and gathering personal protective equipment before entering. Which type of isolation precautions and equipment should the nurse prepare to use? A. Droplet precautions with surgical mask. B. Contact precautions with gloves only. C. Airborne precautions with negative pressure. D. Standard precautions with hand hygiene.
What do you think is the answer?
Correct answer. A. Droplet precautions with surgical mask. Bacterial meningitis spreads through large respiratory droplets that travel short distances during coughing, sneezing, or talking. Droplet precautions require a surgical mask, private room, and mask on patient during transport out of the room. Option B is incorrect, because contact precautions with gloves alone fit organisms spread by direct touch, such as an RSA or C. difficile. Meningitis spreads through respiratory droplets from the nose and mouth, so contact precautions cannot stop transmission. Option C is incorrect because airborne precautions with negative pressure rooms apply to measles, tuberculosis, varicella, and disseminated shingles. Meningitis droplets are heavier and fall within a few feet, so airborne level protection is not required for standard care. Option D is incorrect because standard precautions are the baseline for every patient, but do not include the mask requirement needed to block respiratory droplets. Meningitis demands the added protection of droplet precautions beyond standard hygiene practices. Bacterial meningitis requires droplet precautions, not airborne. The bacteria spread in large respiratory droplets that fall within about 3 to 6 feet during coughing, sneezing, or talking. The nurse needs a surgical mask, a private room, and a mask on the patient during transport. Contact precautions alone miss the respiratory route, which is how meningitis actually moves between people. Airborne precautions with negative pressure and 95 are overkill for meningitis because the droplets are too heavy to float long distances. Reserve airborne for the small particle diseases like measles and TB. Standard precautions cover hand hygiene but never add the mask needed here. Keep it droplet, keep it simple. Here's a WGU D444 OA exam tip for you. Bacterial meningitis equals droplet with surgical mask. Memory hook. Meningitis droplets fall fast. Mask is enough. Question 29. A patient recovering from surgery has just been diagnosed with a wound colonized by methicillin-resistant Staphylococcus aureus. The nurse is updating the care plan and preparing to add appropriate isolation measures to prevent transmission within the unit. Which isolation type is required? A. Droplet precautions with mask worn. B. Contact precautions with gown and gloves. C. Airborne precautions with respirator fitted. D. Reverse isolation with protective gown.
What do you think is the answer?
Correct answer. B. Contact precautions with gown and gloves. MRSA spreads through direct contact with infected wounds, skin, or contaminated surfaces. Contact precautions require gown, gloves, hand hygiene, and dedicated equipment for the patient to stop transmission to staff and other patients. Option A is incorrect because droplet precautions apply to respiratory illnesses that spread by large droplets during coughing or sneezing, such as influenza or meningitis. MRSA in a wound is not airborne or droplet spread, so a mask is not required. Option C is incorrect because airborne precautions with a respirator apply to tuberculosis, measles, varicella, and disseminated shingles. MRSA wound colonization does not spread through air particles, so respiratory protection and negative pressure rooms are not needed. Option D is incorrect because reverse isolation protects an immunocompromised patient from outside pathogens rather than preventing spread from an infected patient. MRSA requires outward contact precautions to protect others, not inward protection for the patient alone. MRSA wound colonization calls for contact precautions with gown and gloves. MRSA spreads through direct contact, such as touching a wound, contaminated dressings, or shared equipment. Gown protects the nurse's uniform, gloves protect the hands, and hand hygiene after care prevents spread to other patients. Dedicated equipment like a stethoscope stays with the patient to keep the organism contained. Droplet precautions with a mask fit flu and meningitis, not skin or wound organisms. Airborne precautions with a respirator fit TB and measles, which float in the air. MRSA never becomes airborne from a wound, so respiratory protection is not needed. Reverse isolation protects immunocompromised patients from outside pathogens, which is the opposite direction of what MRSA requires. Protect others from the patient, not the patient from others. Here's a WGU D444 OA exam tip for you. MRSA wound equals contact precautions. Memory hook. RSA means must gown, gloves, apply. Question 30. A patient with active tuberculosis must be transported from the airborne isolation room to the radiology department for a chest X-ray diag. The nurse is preparing the patient for transport and applying the appropriate protective measures. What should the nurse do during transport? A. Have transport staff wear a 95 respirator. B. Cover the patient with a plastic protective shield. C. Place a surgical mask on the patient. D. Delay the X-ray until isolation period ends.
What do you think is the answer?
Correct answer. C. Place a surgical mask on the patient. When an airborne isolation patient leaves the negative pressure room, a surgical mask is placed on the patient to contain droplet nuclei at the source. This protects staff and bystanders as the patient moves through shared hallways. Option A is incorrect, because transport staff wearing 95 respirators is useful within the patient room, but does not address the risk to others the patient passes in hallways. Source control using a mask on the patient is the priority. Option B is incorrect because plastic shields are not part of airborne isolation transport protocol for tuberculosis patients. The standard approach places a surgical mask on the patient to block the release of infectious droplet nuclei into shared spaces. Option D is incorrect because delaying needed diagnostic imaging could harm the patient by postponing important treatment decisions. Airborne precautions include safe transport protocols, specifically so that patients can receive required care while protecting staff and others. TB patient transport has one golden rule, and it is the reverse of what students often guess. The mask goes on the patient, not on the staff in the hallway. A surgical mask on the patient traps droplet nuclei at the source, right where they are produced, so the particles never reach the air that others breathe. Transport staff wearing a 95 helps inside the negative pressure room, but during hallway transport the priority is source control. People in shared hallways are not wearing respirators, so blocking the bugs before they escape is how everyone stays safe. Plastic shields are not part of TB transport protocol. Delaying the X-ray postpones decisions about the patient's care, so skipping imaging is not an answer. Cover the source. Transport safely. Here's a What You Do D444 OA exam tip for you. TB transport equals surgical mask on the patient. Memory hook. Mask the source, not the staff. Question 31. A nurse is teaching a newly diagnosed patient with celiac disease about dietary changes to prevent intestinal damage and symptom flares. The patient asks, which foods must be permanently avoided to keep the small intestine healthy? Which group of foods should the nurse highlight to avoid? A. Wheat, barley, and rye products. B. Rice, corn, and quinoa grains. C. Fresh meats, eggs, and poultry. D. Fruits, vegetables, and legumes.
Do you know the answer?
Correct answer. A. Wheat, barley, and rye products. Celiac disease is triggered by gluten found in wheat, barley, and rye. Ongoing exposure damages the villi of the small intestine, causing malabsorption, statorrhea, and weight loss, so lifelong avoidance is required. Option B is incorrect, because rice, corn, and quinoa are naturally gluten-free grains that are safe for patients with celiac disease. These grains do not contain the gluten proteins responsible for the autoimmune attack on intestinal villi. Option C is incorrect, because fresh meats, eggs, and poultry are protein sources without gluten and are safe to eat. Patients must watch for added sauces, breading, or marinades that may contain hidden gluten during meal preparation. Option D is incorrect, because fruits, vegetables, and legumes are naturally gluten-free and encouraged as part of a balanced celiac diet. These foods provide fiber, vitamins, and minerals, without triggering the immune response that damages intestinal villi. Celiac disease is an autoimmune response to gluten, and gluten lives in 3 grains that patients must avoid for life. Wheat, barley, and rye are the big 3. When a patient with celiac eats gluten, the immune system attacks the villi of the small intestine, which flattens them and wrecks nutrient absorption. The result is diarrhea, fatty stools, weight loss, and deficiency states. Rice, corn, and quinoa are naturally gluten-free grains and safe for the diet. Fresh meats, eggs, and poultry contain no gluten, though added sauces or breading can sneak it in. Fruits, vegetables, and legumes are gluten-free and actively encouraged. Only wheat, barley, and rye trigger the damage. Here's a D444 OA exam tip for you. Celiac equals avoid wheat, barley, rye. Memory hook, 3 WBR grains wreck the villi. Question 32. A nurse is assessing a patient admitted with a suspected Crohn's disease flare. The patient reports 5 to 6 loose stools daily, pain in the right lower quadrant of the abdomen, weight loss, and fatigue. Which finding is most consistent with Crohn's disease? A. Painless bright red rectal bleeding. B. Upper right quadrant pain with nausea. C. Left upper quadrant pain with vomiting. D. Right lower quadrant pain with diarrhea.
Can you guess the answer?
Correct answer. D. Right lower quadrant pain with diarrhea. Crohn's disease most commonly affects the distal small intestine and proximal colon. Right lower quadrant pain with frequent loose stools, weight loss, and fatigue during flares matches the typical presentation of this inflammatory bowel disease. Option A is incorrect, because painless bright red rectal bleeding is more typical of ulcerative colitis, internal hemorrhoids, or lower GI bleeding. Crohn's disease usually causes cramping pain, stautorrhea, and general inflammation, rather than isolated painless rectal bleeding. Option B is incorrect, because upper right quadrant pain with nausea points toward gallbladder or liver disease, such as cholecystitis or hepatitis. These regions of the abdomen are not where Crohn's disease typically concentrates inflammation during an active flare. Option C is incorrect, because left upper quadrant pain with vomiting is more suggestive of gastric or splenic conditions, rather than Crohn's disease. Crohn's inflammation sits most commonly in the lower right abdomen at the terminal ileum region. Crohn's disease has a signature location, and questions almost always point to the right lower quadrant. Crohn's loves the terminal ileum, which sits in the lower right side of the abdomen where the small intestine meets the colon. Pain there combined with frequent loose stools, weight loss, and fatigue is a textbook flare. Painless, bright red rectal bleeding fits ulcerative colitis or hemorrhoids, not Crohn's. Right upper quadrant pain with nausea points to gallbladder or liver problems. Left upper quadrant pain with vomiting suggests stomach or spleen issues. When you see right lower quadrant, plus diarrhea, plus weight loss, think Crohn's. The location and the symptom cluster work together. Here's a D444 OA exam tip for you. Crohn's equals right lower quadrant plus diarrhea. Memory hook, Crohn's corners the right lower quadrant. Question 33. A patient diagnosed with celiac disease is meeting with a dietitian and nurse for follow-up education after 3 months on the new diet. The patient asks which specific food items from the following list are safe to keep in the regular meal rotation. Which option represents safe choices? A. Whole wheat, bread and barley soup. B. Quinoa salad and corn tortillas. C. Wheat pasta and breaded chicken. D. Regular beer and rye crackers.
What do you think is the answer?
Correct answer. B. Quinoa salad and corn tortillas. Quinoa and corn are naturally gluten-free grains that are safe for patients with celiac disease. These foods allow patients to enjoy variety in meals while avoiding the gluten proteins that damage the intestinal villi. Option A is incorrect, because whole wheat bread and barley soup both contain gluten that triggers the autoimmune attack on the small intestine. Even small amounts of gluten can cause intestinal damage and reactivate symptoms in patients with celiac disease. Option C is incorrect, because wheat pasta is made from wheat flour, and breaded chicken is coated in wheat-based breadcrumbs. Both dishes contain gluten and would trigger symptoms and ongoing damage in patients with celiac disease. Option D is incorrect, because regular beer is brewed from barley and rye crackers contain rye flour, so both items contain gluten. Patients with celiac disease must choose specifically labeled gluten-free alternatives for beverages and crackers. Safe food choices for celiac come down to avoiding gluten in any form. The correct answer is quinoa salad and corn tortillas. Quinoa is a seed that cooks like a grain and has no gluten. Corn tortillas are made from corn flour, also gluten-free. Both choices let patients enjoy variety without damaging the villi. Whole wheat bread and barley soup are double failures because both contain gluten proteins that trigger the autoimmune attack. Wheat pasta and breaded chicken sneak in wheat in two places, the pasta itself and the breadcrumb coating. Regular beer is brewed from barley, and rye crackers are made from rye flour, so that combination doubles the exposure. Patients need to read labels obsessively and trust specifically labeled gluten-free products for anything processed. Here is a D444 OA exam tip for you. Safe celiac foods equal rice, corn, quinoa, meats, fruits, and vegetables. Memory hook: naturally grown, naturally safe. Question 34. Tutors. A patient hospitalized with a severe Crohn's disease exacerbation has been placed on complete bowel rest with total parenteral nutrition. The patient asks the nurse why eating regular meals is restricted during this acute phase of illness. What is the nurse's best response? A. Food passing through the inflamed intestine worsens symptoms. B. Hospital menus are not nutritionally balanced enough. C. Bowel rest allows inflamed intestinal tissue to heal. D. Cell. TPN provides higher calories than oral meals.
Can you guess the answer?
Correct answer: C. Bowel rest allows inflamed intestinal tissue to heal. Bowel rest during severe Crohn's flares reduces the mechanical and chemical stress of food passing over inflamed tissue. Complete rest, combined with TPN, supports healing of ulcerations and reduces diarrhea, cramping, and nutrient loss. Option A is incorrect, because while food does pass over inflamed tissue, the best response focuses on what bowel rest accomplishes for the healing process. The priority concept is providing intestinal tissue a chance to heal rather than just reducing irritation. Option B is incorrect, because hospital menus are nutritionally balanced and supervised by dietitians. The reason for bowel rest has nothing to do with menu quality. It is based on reducing irritation of inflamed bowel tissue during a severe flare. Option D is incorrect, because while TPN can deliver high calories, the primary purpose of bowel rest is tissue healing rather than caloric delivery alone. Patients could often meet caloric needs orally once the bowel is no longer severely inflamed. Bowel rest during a severe Crohn's flare has one main goal, which is to let inflamed intestinal tissue heal. When food stops passing through the bowel, there is no mechanical scraping, no chemical exposure, and no absorption demand on the damaged mucosa. Ulcerations start to close. Inflammation drops, and symptoms, like cramping and diarrhea, settle down. TPN covers the nutritional side while the bowel takes a break. The simpler answer, that food passing through worsens symptoms, is partially true but misses the deeper reason. The priority concept is tissue healing, not just symptom reduction. Hospital menus are not the problem. TPN calories are not the point either. Patients could eat enough calories orally once the bowel settles. The key word is rest, so the tissue can heal. Here's a D444 OA exam tip for you. Bowel rest equals tissue healing in Crohn's. Memory hook: rest to heal, not just to relieve. Question 35. A nurse is monitoring a patient with long-standing Crohn's disease who has developed scarring in the small intestine after repeated flares. The patient is at risk for several long-term complications related to this scarring and chronic inflammation. Which complication is most concerning? A. Intestinal obstruction and fistula formation. B. Rapid upper gastrointestinal bleeding. C. Sudden pancreatic enzyme deficiency. D. Immediate liver cirrhosis development.
Can you guess the answer?
Correct answer: A. intestinal obstruction and fistula formation. Chronic Crohn's inflammation and repeated scarring narrow the intestinal lumen and create abnormal tunnels between bowel loops or adjacent organs. Obstruction and fistula formation are classic complications that may require surgical resection to fix. Option B is incorrect, because rapid upper gastrointestinal bleeding is more typical of peptic ulcers, esophageal varices, or gastritis. Crohn's disease generally causes chronic blood loss rather than sudden massive upper GI hemorrhage from the small intestine or colon. Option C is incorrect, because sudden pancreatic enzyme deficiency is associated with pancreatitis or cystic fibrosis rather than Crohn's disease. The small intestine inflammation in Crohn's does not typically cause an abrupt loss of pancreatic secretion or function. Option D is incorrect, because liver cirrhosis develops over years and is linked to hepatitis, alcohol abuse, and biliary disease rather than Crohn's disease. While primary sclerosing cholangitis can occur, immediate cirrhosis is not a typical Crohn's complication. Long-standing Crohn's disease scars the bowel over years of repeated inflammation, and the classic complications are obstruction and fistula formation. Scar tissue narrows the intestinal lumen, so food and fluid cannot pass through, which causes cramping, distension, vomiting, and absent stools. Fistulas are abnormal tunnels that burrow between loops of bowel or into nearby organs, like the bladder or skin. Both complications may require surgical resection to fix. Rapid upper gastrointestinal bleeding is more typical of peptic ulcers or esophageal varices. Sudden pancreatic enzyme deficiency fits pancreatitis or cystic fibrosis, not Crohn's. Immediate liver cirrhosis is linked to alcohol, hepatitis, or biliary disease over years. Here's a D444 OA exam tip for you. Chronic Crohn's equals obstruction plus fistulas. Memory hook. Scars narrow the tube, tunnels break the wall. Question 36. A patient newly diagnosed with GERD is meeting with the nurse for education on lifestyle changes to reduce reflux and esophageal damage. The patient asks which behaviors at home can help control symptoms beyond medication. Which teaching should the nurse include? A. Drink several cups of coffee with each meal. B. Lie flat in bed right after eating dinner. C. Smoke a cigarette to reduce stomach acid. D. Elevate the head of the bed at night.
Can you guess the answer?
Correct answer. D. Elevate the head of the bed at night. Elevating the head of the bed uses gravity to keep stomach contents below the lower esophageal sphincter during sleep. This simple adjustment reduces nighttime reflux episodes and protects the esophagus from acid damage. Option A is incorrect, because coffee is a known trigger for GERD because caffeine relaxes the lower esophageal sphincter and increases stomach acid production. Multiple cups per meal would worsen reflux symptoms and increase esophageal irritation over time. Option B is incorrect, because lying flat immediately after eating allows stomach contents to flow backward into the esophagus, which worsens GERD symptoms. Patients should wait at least 3 hours after meals before lying down to avoid reflux episodes. Option C is incorrect because smoking weakens the lower esophageal sphincter and increases acid exposure to the esophagus, making GERD much worse. Cessation counseling is part of standard GERD teaching, not smoking as a symptom control strategy. GERD lifestyle teaching comes down to managing gravity and trigger foods. Elevating the head of the bed at night is the winning answer. Raising the head of the bed by 6 to 8 inches uses gravity to keep stomach acid below the lower esophageal sphincter during sleep. This single change reduces nighttime reflux and protects the esophagus from acid exposure over hours of lying down. Coffee with meals is a trigger, not a treatment. Caffeine relaxes the sphincter and raises acid production, so multiple cups per meal is actively harmful. Lying flat right after dinner drops the diaphragm's help, so stomach contents flow backward easily. Smoking weakens the sphincter and worsens acid exposure, which is why smoking cessation is standard GERD teaching. Height of bed up, food triggers down. Here's a D444 OA exam tip for you. GERD equals head of bed elevated at night. Memory hook. Gravity guards the esophagus. Question 37. A patient is being treated for an H. pylori infection that has caused peptic ulcers and gastric pain. The nurse reviews the patient's medication list to identify any drug that should be discontinued while the ulcer heals. Which medication class is most concerning? A. Oral proton pump inhibitors. B. Non-steroidal anti-inflammatory drugs. C. Broad-spectrum oral antibiotics. D. Standard antacid combination tablets.
Do you know the answer?
Correct answer. B. Non-steroidal anti-inflammatory drugs. NSAIDs such as ibuprofen, aspirin, and naproxen damage the protective stomach lining and worsen H. pylori-related ulcers. Stopping these medications protects the gastric mucosa and allows ulcer healing during the antibiotic course. Option A is incorrect because proton pump inhibitors are actually part of standard H. pylori treatment regimens because they reduce acid production and support ulcer healing. Patients typically continue PS alongside antibiotics for several weeks of therapy. Option C is incorrect because broad-spectrum antibiotics such as amoxicillin, clarithromycin, and metronidazole are core components of H. pylori treatment. Stopping these medications would prevent eradication of the bacteria and leave the ulcers at ongoing risk of recurrence. Option D is incorrect because standard antacids neutralize existing stomach acid and provide symptom relief without harming the gastric lining. They are compatible with H. pylori treatment and may be continued as needed for breakthrough indigestion during therapy. H. pylori ulcer treatment has a core rule, and it is to stop the drugs that hurt the stomach lining. NSAIDs like ibuprofen, aspirin, and naproxen are the concerning class. These drugs block prostaglandins that normally protect the gastric mucosa, and when that protection goes away, the stomach lining erodes faster. Combine NSAID damage with the ulcer already caused by H. pylori, and healing stalls. Proton pump inhibitors are actually part of the treatment regimen because they reduce acid production and let the ulcer close. Broad-spectrum antibiotics like amoxicillin and clarithromycin are the core of H. pylori eradication, so stopping them would leave the infection intact. Standard antacids neutralize acid already in the stomach without harming the lining, so they stay on the list as needed. The class to pull is NSAIDs. Here's a D444 OA exam tip for you. H. pylori plus NSAID equals stop the NSAID. Memory hook, NSAIDs eat the lining, pull them out. Question 38. A patient recently diagnosed with a hiatal hernia wants to know what lifestyle changes can help prevent symptoms and avoid surgery. The nurse provides teaching on behaviors that reduce intra-abdominal pressure and reflux. Which instruction should the nurse include? A. Wear tight belts to support the abdomen. B. Lift heavy weights daily for core strength. C. Eat small, frequent, low-fat meals. D. Lie down immediately after each meal.
What do you think is the answer?
Correct answer. C. Eat small, frequent, low-fat meals. Small, frequent, low-fat meals reduce stomach distension and lower the pressure on the diaphragm. This approach decreases the risk of gastric contents pushing upward through the hernia opening and causing reflux symptoms. Option A is incorrect because tight belts and restrictive clothing raise intra-abdominal pressure and push stomach contents upward through the hernia opening. Patients with hiatal hernia should avoid tight waistbands to reduce reflux and discomfort throughout the day. Option B is incorrect because lifting heavy weights raises intra-abdominal pressure and can push more stomach tissue through the weakened diaphragm opening. Patients with hiatal hernia are specifically advised to avoid heavy lifting and straining during workouts. Option D is incorrect because lying down immediately after meals allows gastric contents to flow back through the hernia and into the esophagus. Patients should remain upright for at least 3 hours after eating to reduce reflux events. Hiatal hernia teaching centers on reducing intra-abdominal pressure. The correct answer is small, frequent, low-fat meals. Small meals mean less stomach distension, so less pressure pushes gastric contents upward through the hernia opening. Low-fat meals empty faster, which also reduces time for reflux. Frequent meals keep the stomach supplied without ever overfilling it. Tight belts raise intra-abdominal pressure directly, so patients avoid waistbands that squeeze the belly. Heavy lifting and straining push more stomach tissue through the weakened diaphragm opening, worsening the hernia over time. Lying down right after eating flips gravity against the patient, allowing gastric contents to flow back through the hernia and irritate the esophagus. Patients should stay upright for at least 3 hours after meals. Here's a what do you do D444 OA exam tip for you. Hiatal hernia equals small, frequent, low-fat meals. Memory hook, less in the belly, less through the hole. Question 39. A patient being treated for GERD suddenly develops a rigid, board-like abdomen, fever, rebound tenderness, and tachycardia after several days of worsening epigastric pain. The nurse recognizes these findings as a serious complication and prepares to notify the provider. Which complication is developing? A. Peritonitis from perforated ulcer. B. Simple diverticulitis, flare-up. C. Routine muscle strain injury. D. Common irritable bowel episode.
Can you guess the answer?
Correct answer. A. Peritonitis from perforated ulcer. A rigid board-like abdomen with fever, rebound tenderness, and tachycardia signals peritonitis, often from a perforated gastric or duodenal ulcer. This is a surgical emergency requiring immediate provider notification and preparation for operative repair. Option B is incorrect, because simple diverticulitis produces left lower quadrant pain and fever, but does not cause a board-like rigid abdomen or the full peritoneal picture. The findings described point to a full-thickness perforation rather than localized inflammation. Option C is incorrect, because muscle strain causes localized tenderness with movement, but does not produce fever, rebound tenderness, or a rigid board-like abdomen. These systemic signs always point toward an intra-abdominal emergency rather than a musculoskeletal problem. Option D is incorrect, because irritable bowel syndrome causes cramping and altered bowel habits without fever or rigid abdomen on examination. The severe systemic findings described here rule out functional bowel disorders and point to a true surgical emergency. A rigid board-like abdomen is one of the most specific findings in nursing assessment. Add fever, rebound tenderness, and tachycardia, and the picture is peritonitis, most likely from a perforated ulcer. The ulcer has eaten through the full thickness of the stomach or duodenum wall, spilling acid and bacteria into the sterile peritoneal cavity. The peritoneum becomes inflamed, the abdominal muscles guard reflexively, and the patient spirals fast towards sepsis. This is a surgical emergency. The provider needs to know now, and the operating room needs to be ready. Diverticulitis causes left lower quadrant pain and fever, but not a rigid board-like abdomen. Muscle strain produces localized tenderness without systemic signs. Irritable bowel syndrome never causes fever or rigidity. Rigid abdomen plus systemic signs equals get moving. Here's a D444 OA exam tip for you. Board-like abdomen plus fever equals peritonitis. Memory hook, rigid belly rings the surgical alarm. Question 40. A patient with chronic GERD has been prescribed a medication that works by blocking acid production in the stomach rather than neutralizing existing acid. The nurse recognizes this description, matches a specific drug class. Which medication class does this describe? A. Sucralfate coating agents. B. Simple calcium-based antacids. C. Histamine H2 receptor blockers. D. Proton pump inhibitors.
Can you guess the answer?
Correct answer. D. Proton pump inhibitors. Proton pump inhibitors, such as omeprazole and pantoprazole, shut down the acid-producing pumps in the stomach lining. They provide strong and lasting acid suppression, which is superior to antacids, or H2 blockers, for chronic GERD. Option A is incorrect because sucralfate forms a protective coating over ulcers and damaged mucosa rather than blocking acid production. It is a mucosal protectant, not an acid reducer, so it does not match the description of blocking acid secretion. Option B is incorrect because calcium-based antacids neutralize acid already in the stomach rather than blocking new acid production. They provide quick but short relief and are not the drug class described in this scenario for long-term GERD control. Option C is incorrect because histamine H2 receptor blockers such as famotidine reduce acid production through a different pathway than proton pump inhibitors. They are weaker than PS and do not match the description of shutting down acid pumps directly. GERD medications come in three main categories, and this question tests the strongest one. Proton pump inhibitors, or PIs, shut down the actual acid-producing pumps in the stomach lining. Drugs like omeprazole and pantoprazole block hydrogen-potassium ATPase, which is the pump that secretes hydrogen ions into the stomach. Without the pumps working, acid production drops dramatically, and the esophagus gets time to heal. Sucralfate is a mucosal protectant that coats ulcers with a sticky barrier. It does not touch acid production at all. Simple antacids like calcium carbonate neutralize acid already in the stomach, providing fast but short relief. H2 receptor blockers like famotidine reduce acid production through histamine receptors, which is a different pathway and a weaker effect than PIs. For chronic GERD control, PIs are the heavy hitters. Here's a YGU D444 OA exam tip for you. PIs equal block acid production at the pump. Memory hook, pump producers, pantoprazole, and omeprazole. Question 41. A nurse is providing teaching to a patient newly diagnosed with multiple sclerosis about common triggers that can cause relapse or worsen symptoms. The patient wants to continue working and raising children while managing the disease. Which factor should the nurse warn the patient to avoid? A. Regular, moderate physical exercise. B. Adequate, nightly sleep and rest. C. Overheating from hot baths or saunas. D. Eating a balanced diet with vegetables.
Can you guess the answer?
Correct answer. C. Overheating from hot baths or saunas. Heat exposure worsens demyelination symptoms in multiple sclerosis by slowing nerve conduction through damaged myelin. Patients are taught to avoid hot baths, saunas, and extreme outdoor heat because these triggers can provoke symptom flares. Option A is incorrect because moderate physical exercise is actually recommended for patients with multiple sclerosis to maintain muscle strength, balance, and overall function. Regular activity helps manage fatigue and spasticity rather than triggering symptoms or relapses in most cases. Option B is incorrect because adequate sleep and rest are protective factors in multiple sclerosis because fatigue is one of the most disabling symptoms. Good sleep habits reduce daytime fatigue and help patients maintain function during the day. Option D is incorrect because a balanced diet with vegetables is encouraged for overall health and may support immune function in multiple sclerosis patients. No standard dietary restrictions apply, so healthy eating is beneficial rather than a trigger. Multiple sclerosis teaching almost always includes a warning about heat. The correct answer is overheating from hot baths or saunas. Heat slows nerve conduction through already damaged myelin, so symptoms flare when body temperature rises. Patients may notice blurred vision, weakness, or fatigue worsening after a hot shower, a sauna, or even a warm summer day. This pattern even has a name, Euthoff's phenomenon. Moderate exercise is recommended, not avoided, because it preserves muscle strength and reduces fatigue over time. Adequate sleep is actively protective because fatigue is one of the most disabling MS symptoms. A balanced diet with vegetables supports general health and may help immune function, so it is encouraged. The trigger to watch is heat, not healthy habits. Here's a YGU D444 OA exam tip for you. This equals avoid overheating. Memory hook. This melts in the heat. Question 42. A patient's adult child is scheduled for genetic counseling because a parent has just been diagnosed with Huntington's disease. The adult child asks the nurse about the inheritance pattern of this condition to prepare for the counseling session. What is the best response? A. It skips generations in most affected families. B. Autosomal dominant with 50% transmission risk. C. X-linked recessive, affecting mainly males. D. Mitochondrial inheritance from mother only.
Do you know the answer?
Correct answer. B. Autosomal dominant with 50% transmission risk. Huntington's disease follows an autosomal dominant inheritance pattern, so each child of an affected parent has a 50% chance of inheriting the abnormal gene. The disorder affects males and females equally across generations. Option A is incorrect because autosomal dominant conditions like Huntington's disease do not skip generations because one copy of the mutated gene causes disease. Every affected person has an affected parent, which is the opposite of a generation-skipping pattern. Option C is incorrect because X-linked recessive inheritance would primarily affect males and would not match the equal male-to-female ratio seen in Huntington's. The gene for Huntington's sits on an autosome, not on the X chromosome at all. Option D is incorrect because mitochondrial inheritance would come only from the mother and would affect all offspring of an affected mother. Huntington's can be inherited from either parent, which rules out the mitochondrial pattern of transmission entirely. Huntington's disease is inherited through an autosomal dominant pattern with a 50% transmission risk. That means only one copy of the defective gene is needed to cause disease, and each child of an affected parent has a 1 in 2 chance of inheriting it. The gene sits on an autosome, not a sex chromosome, so males and females are affected equally. Autosomal dominant conditions do not skip generations, because every person with the gene develops the disease at some point. X-linked recessive inheritance would show mostly male cases, which does not fit Huntington's. Mitochondrial inheritance passes only from the mother, and Huntington's can come from either parent. Genetic counseling helps families understand the 50% odds for each pregnancy, since each child's risk is independent of siblings. Here's a D444 OA exam tip for you. Huntington's equals autosomal dominant, 50% risk. Now, Allah, I'll intendo, well. But memory hook, Huntington's hits half. Question 43. A nurse is assessing a patient with suspected myasthenia gravis who reports progressive weakness throughout the day. The nurse asks about the timing and pattern of the weakness to confirm the diagnostic suspicion. Which pattern of symptoms is most consistent with this condition? A. Weakness worsens with activity, improves with rest. B. Pain increases with cold exposure and humidity. C. Stiffness develops mainly during early morning hours. D. Tremors appear suddenly when the patient is startled.
Do you know the answer?
Correct answer. A. Weakness worsens with activity, improves with rest. Myasthenia gravis causes muscle weakness that gets worse with repeated use and improves with rest. Antibodies destroy acetylcholine receptors at the neuromuscular junction, so prolonged activity depletes signal transmission, which recovers after resting. Option B is incorrect because pain linked to cold exposure and humidity is more characteristic of arthritis rather than myasthenia gravis. Myasthenia is defined by activity-related weakness affecting voluntary muscles, not by climate-related pain patterns or temperature changes. Option C is incorrect because morning stiffness is a hallmark of rheumatoid arthritis or Parkinson's disease rather than myasthenia gravis. Myasthenia weakness tends to worsen as the day goes on, and the patient uses muscles repeatedly across activities. Option D is incorrect because sudden tremors triggered by surprise fit a startle disorder or anxiety response rather than myasthenia gravis. Myasthenia produces gradual weakness during sustained effort, not sudden tremor reactions to external stimuli or emotional events. Myasthenia gravis has a signature symptom pattern, and exam questions love to test it. The right answer is weakness, that worsens with activity and improves with rest. Here is the mechanism. Antibodies destroy acetylcholine receptors at the neuromuscular junction, so each muscle contraction uses up signal transmission that cannot be replaced fast enough. Morning strength drops through the day as the patient uses muscles repeatedly. Rest lets the remaining receptors recover their function. Pain linked to cold and humidity fits arthritis, not myasthenia. Morning stiffness points to rheumatoid arthritis or Parkinson's disease. Sudden tremors with startle suggest anxiety or a startle disorder, not a neuromuscular junction problem. The defining feature is fatigable weakness, getting worse with use and better with rest. Here's a D444 OA exam tip for you. Myasthenia gravis equals weakness worse with activity, better with rest. Memory hook. Myasthenia melts with use, mends with rest. Question 44. A patient with myasthenia gravis is admitted for management of worsening symptoms, including drooping eyelids and inability to keep the eyes closed during sleep. The nurse plans interventions to protect the cornea from drying and damage during the hospital stay. Which action should the nurse take? A. Apply warm compresses to the eyelids hourly. B. Encourage the patient to rub the eyes often. C. Place bright lights in the room at night. D. Tape the eyelids shut during sleep hours.
Do you know the answer?
Correct answer. D. Tape the eyelids shut during sleep hours. Patients with severe myasthenia may not fully close the eyelids during sleep, which exposes the cornea to drying and damage. Taping the eyelids shut protects the cornea overnight and prevents abrasions or ulcerations from forming. Option A is incorrect because warm compresses can soothe tired eyes but do not protect the cornea from drying damage caused by incomplete eyelid closure. The priority problem is exposure, which requires mechanical closure rather than intermittent warmth alone. Option B is incorrect because encouraging the patient to rub the eyes can introduce bacteria and cause mechanical injury to a vulnerable cornea. Eye rubbing is always discouraged during ocular care, especially when the cornea is at risk for abrasion. Option C is incorrect because bright lights do not protect the cornea and may actually disrupt the patient's sleep and comfort. Environmental lighting changes do not address the underlying mechanical problem of incomplete eyelid closure during rest and sleep. Myasthenia gravis weakens all voluntary muscles, including the ones that close the eyelids. When the patient cannot fully close the eyes during sleep, the cornea gets exposed to air for hours, dries out, and risks abrasion or ulceration. The correct nursing action is to tape the eyelids shut during sleep. Taping mechanically closes the eyes when the muscles cannot, protecting the delicate corneal surface overnight. Warm compresses feel good but do not address exposure, which is the actual problem. Encouraging eye rubbing is never right, because rubbing introduces bacteria and can scratch an already vulnerable cornea. Bright lights at night do nothing for exposure and will disrupt sleep. The priority is mechanical closure to prevent drying injury. Here's a D444 OA exam tip for you. Myasthenia with drooping lids equals tape eyes shut at night. Memory hook. Tape the lids, save the cornea. Question 45. A patient diagnosed with multiple sclerosis 2 years ago reports new episodes of seeing double images and difficulty with balance while walking. The nurse recognizes these findings as typical multiple sclerosis symptoms caused by myelin damage in specific nervous system areas. Which other symptom commonly occurs? A. Productive cough with thick yellow sputum. B. Muscle spasticity and sudden stiffness. C. Painless enlargement of cervical lymph nodes. D. Pulsating severe headache with aura.
Do you know the answer?
Correct answer. B. Muscle spasticity and sudden stiffness. Multiple sclerosis affects the myelin sheath in the central nervous system, which leads to muscle spasticity, stiffness, weakness, and coordination problems. Vision changes, balance issues, and bladder dysfunction also commonly appear during relapses over time. Option A is incorrect because productive cough with yellow sputum points toward a lung infection such as pneumonia or bronchitis rather than multiple sclerosis. Respiratory infections are not a direct symptom of demyelination within the central nervous system pathways. Option C is incorrect because painless cervical lymph node enlargement suggests lymphoma, leukemia, or an infection rather than multiple sclerosis. Lymphatic changes are not part of the demyelinating process that damages nerve transmission pathways in the central nervous system. Option D is incorrect because pulsating severe headache with aura is characteristic of migraine headaches rather than multiple sclerosis. While some MS patients have headaches, the defining symptoms are motor, sensory, and visual changes from nerve conduction impairment. Multiple sclerosis damages myelin in the central nervous system, and symptoms line up with the nerve tracts that lose their insulation. This patient already has double vision and balance problems from cranial and cerebellar involvement. Another common symptom is muscle spasticity with sudden stiffness. Damaged corticospinal tracts send disorganized signals to muscles, which contract too strongly or at the wrong times, producing spasticity and stiff movements. Productive cough with yellow sputum describes a lung infection like pneumonia, not demyelination. Painless cervical lymph node swelling points to lymphoma or leukemia. Pulsating headache with aura is a migraine pattern, not Ms. The MS symptom family includes vision changes, balance issues, spasticity, weakness, bladder problems, and fatigue. Here's a D444 OA exam tip for you. Ms equals spasticity, vision changes, balance issues. Memory hook, Ms muddles motor signals. Question 46. A nurse is reviewing a new order for ketorolac in a patient with moderate postoperative pain. The pharmacist calls to confirm an important limit on the duration of this medication that the nurse must include in patient teaching. What is the maximum recommended duration? A. 14 days of continuous use. B. 10 days with daily monitoring. C. 5 days total of therapy. D. 30 days for chronic conditions.
Do you know the answer?
Correct answer. C. 5 days total of therapy. Ketorolac is limited to 5 days of therapy because it carries high risk of gastrointestinal bleeding, kidney injury, and cardiovascular events with longer use. The short duration balances pain relief with serious adverse risks. Option A is incorrect because 14 days of continuous ketorolac use significantly raises the risk of kidney damage, GI bleeding, and cardiovascular complications. The prescribing guidelines specifically cap therapy at 5 days to prevent these serious adverse outcomes. Option B is incorrect because 10 days exceeds the maximum recommended duration for ketorolac and places the patient at increased risk for bleeding and renal failure. The correct limit of 5 days reflects the strong safety warnings on this medication. Option D is incorrect because 30 days of ketorolac therapy would dramatically increase the likelihood of serious complications such as acute kidney injury and gastrointestinal hemorrhage. This drug is never used for chronic pain management due to these risks. Ketorolac has a strict duration limit that every nurse needs to know, and it is 5 days total of therapy. This NSAID is powerful, offering pain relief similar to some opioids, but it carries serious risks. Long use raises the chance of gastrointestinal bleeding, acute kidney injury, and cardiovascular events. The 5-day cap balances pain relief against these dangers. 14 days of continuous use is far beyond the safety window and greatly increases harm. 10 days with daily monitoring still exceeds the recommended limit, and monitoring does not reverse the underlying risk. 30 days for chronic conditions is especially wrong because ketorolac is never used for chronic pain management, only for short-term moderate to severe acute pain. The combined oral and intravenous duration must stay within 5 days to protect the patient. Here's a D444 OA exam tip for you. Ketorolac equals 5-day maximum. Memory hook. Ketorolac keeps to 5 days. Question 47. A patient with liver cirrhosis is prescribed lactulose because of rising ammonia levels and early signs of hepatic encephalopathy, including confusion and lethargy. The family asks how this sweet syrup actually helps the patient's mental status. What is the nurse's best response? A. It removes ammonia through increased bowel movements. B. It replaces missing insulin to control blood sugar. And C. It directly sedates the brain to prevent agitation. D. It strengthens the liver cells to improve function.
Do you know the answer?
Correct answer. A. It removes ammonia through increased bowel movements. Lactulose draws water into the stool and converts ammonia into a form that cannot be reabsorbed. Increased bowel movements flush ammonia from the body, which lowers blood levels and improves mental status and hepatic encephalopathy. Option B is incorrect because lactulose has no effect on insulin levels or blood sugar regulation. While it is a sugar-based laxative, it does not replace pancreatic hormones, and patients with diabetes still need their regular glucose management plan. Option C is incorrect because lactulose does not act directly on the brain or sedate the patient. Mental status improves indirectly through ammonia removal via the bowel, not through a central nervous system effect from the medication itself. Option D is incorrect because lactulose does not repair damaged liver cells or improve liver synthetic function. It only manages the downstream consequence of liver failure by lowering circulating ammonia, which reduces neurologic symptoms without healing the liver itself. Lactulose is a sweet syrup with a surprising purpose in liver disease. The right answer is that it removes ammonia through increased bowel movements. Here is the pathway. In liver failure, the damaged liver cannot convert ammonia into urea the way a healthy liver does. So ammonia builds up in the blood and crosses into the brain, causing confusion, lethargy, and eventually coma. Lactulose works in the gut. It acidifies the colon, trapping ammonia as ammonium, which cannot be reabsorbed. Then it draws water into the stool and pushes the ammonium out through bowel movements. More stools, less ammonia, clearer thinking. Lactulose has nothing to do with insulin, so blood sugar answers are wrong. It does not sedate the brain directly. It does not repair liver cells either, which is why patients still need long-term liver care. Here's a D444 OA exam tip for you. Lactulose equals ammonia out through the bowel. Memory hook. Lactulose lowers ammonia, loosens stool die. Question 48. A nurse is preparing to administer ipratropium inhalation therapy to a patient with COPD who has been admitted for increasing shortness of breath. Before administering the medication, the nurse reviews the patient's allergy history for an important contraindication. Which allergy would make this medication unsafe? A. Dairy milk allergy with stomach upset. B. Shellfish allergy causing mild rash. C. Pollen allergy with seasonal sneezing. D. Peanut allergy with past anaphylaxis.
Can you guess the answer?
Correct answer. D. Peanut allergy with past anaphylaxis. Ipratropium contains soy lecithin, which cross-reacts in some patients with peanut allergy. A patient with documented peanut allergy and prior anaphylaxis should not receive ipratropium due to the risk of severe allergic reaction. Option A is incorrect because dairy milk allergy with stomach upset does not cross-react with ipratropium ingredients. While milk protein allergy requires attention in some inhalers, ipratropium itself is not contraindicated in patients with mild dairy-related gastrointestinal symptoms. Option B is incorrect because shellfish allergy causing mild rash does not contraindicate ipratropium therapy. The cross-reactive concern for ipratropium is specifically related to soy lecithin in the formulation, which links to peanut rather than shellfish allergens. Option C is incorrect because seasonal pollen allergies with sneezing, Do not contraindicate ipratropium or any other respiratory inhaled medications. This type of allergy is environmental and does not cross-react with the excipients used in ipratropium. Ipratropium is a common inhaled anticholinergic for COPD, but it has one important allergy to check for. The correct answer is peanut allergy with past anaphylaxis. Ipratropium contains soy lecithin, and soy lecithin shares protein similarities with peanut allergens, so patients with severe peanut allergy can react to the inhaler. The risk is serious, up to anaphylaxis, so the drug is contraindicated. Dairy milk allergy with stomach upset does not cross-react with ipratropium components. Some inhalers contain lactose and require caution there, but ipratropium itself is safe with mild dairy issues. Shellfish allergy with mild rash does not connect to soy lecithin, so that allergy does not block ipratropium use. Pollen allergy with seasonal sneezing is environmental and does not cross-react with any inhaled respiratory medication. The one to watch is peanut plus anaphylaxis. Here's a D444 OA exam tip for you. Ipratropium equals check for peanut anaphylaxis. Memory hook. Ipratropium plus peanut equals problem. Question 49. A nurse is infusing intravenous vancomycin when the patient suddenly develops flushing, red rash on the face and chest, and itching. The blood pressure is also beginning to drop. The nurse recognizes a specific adverse reaction and prepares to intervene immediately. What should the nurse do first? A. Switch the medication to oral route. B. Stop the infusion immediately. C. Increase the infusion rate to finish quickly. D. Administer oxygen and continue infusion.
What do you think is the answer?
Correct answer. B. Stop the infusion immediately. Red man syndrome occurs when vancomycin is infused too quickly and causes histamine release, with flushing, rash, and hypotension. The first action is to stop the infusion and notify the provider before restarting the therapy. Option A is incorrect, because switching to oral vancomycin does not address the active histamine reaction happening right now. Also, oral vancomycin is only used for C. difficile rather than the systemic infections that require intravenous therapy. Option C is incorrect because increasing the infusion rate would worsen red man syndrome because the reaction is directly triggered by fast vancomycin infusion. The correct action is to slow or stop the rate rather than push the medication faster. Option D is incorrect because administering oxygen without stopping the infusion continues the cause of the reaction. The priority intervention is removing the trigger by stopping vancomycin first, then addressing any respiratory or cardiovascular support needs. To really understand why avoiding daytime caffeine sits at the top of the list, you have to look at how caffeine actually behaves inside the body. Caffeine has a long half-life, which means half of what you drank at noon is still active in your system hours later. A coffee at 3 in the afternoon can still be holding your brain awake at 10 at night. Stopping the drug removes the trigger, so histamine release can settle and the reaction can resolve. Providers then usually reorder vancomycin at a slower rate, often over 90 minutes or longer, sometimes with premedication. Switching to oral vancomycin does not help because oral vancomycin only treats C. difficile in the gut, not systemic infections. Increasing the infusion rate would push more drug in faster and worsen the reaction, the opposite of what the patient needs. Giving oxygen while continuing the infusion keeps the trigger active and does not address the cause. Stop the drug first, always. Here's a D444 OA exam tip for you. Red man syndrome equals stop the vancomycin infusion. Memory hook, red rash, stop the run. Question 50. A patient calls the clinic 3 days after developing flu-like symptoms, including fever, body aches, and cough. The patient asks if it is still worth starting oseltamivir to treat the influenza at this point. What is the nurse's best response based on timing guidelines? A. Start the medication only after fever resolves. B. Oseltamivir must begin within 1 hour of symptoms. C. Best results occur when started within 48 hours. D. Wait for a positive rapid flu test before starting.
Do you know the answer?
Correct answer. C. Best results occur when started within 48 hours. Oseltamivir works best when started within 48 hours of symptom onset because it inhibits viral replication most effectively early in the infection. Starting outside this window limits the reduction in illness duration for most patients. Option A is incorrect, because waiting for fever to resolve delays oseltamivir past the optimal treatment window. The goal is to start therapy while the virus is actively replicating, not after symptoms have already begun to subside on their own. Option B is incorrect, because a 1-hour window is far too narrow and not supported by oseltamivir clinical guidelines. Most patients do not recognize flu symptoms that quickly, so this timing would make the medication almost unusable in practice. Option D is incorrect, because waiting for a positive rapid flu test can be reasonable in some settings, but delays treatment beyond the optimal window. Empirical treatment is often started based on clinical symptoms alone during peak flu season. Oseltamivir, brand name Tamiflu, has a timing rule that patients often forget. The best results occur when the medication is started within 48 hours of symptom onset. Inside that window, oseltamivir inhibits viral replication effectively, shortens illness duration, and reduces complication risk. Outside that window, the virus has already replicated heavily, and the drug gives much less benefit. Waiting for fever to resolve delays treatment past the optimal window, so that answer fails. A 1-hour window is far too tight because most people do not recognize flu symptoms that quickly, making the drug almost unusable in practice. Waiting for a positive rapid flu test can delay treatment too long, especially during peak flu season, when clinical symptoms alone are often enough to start therapy. 3 days in, benefit is limited, though sometimes still considered for high-risk patients. The key number is 48 hours. Here's a BEGU D444 OA exam tip for you. Oseltamivir equals start within 48 hours. Memory hook. Tamiflu takes effect when timely.
You have reached the end of our first question set. For the free complete exam preparation, visit our website, link in the description, where you find thousands more practice questions and comprehensive study guides. Thanks for studying with us today. See you in the next video.